Welcome back to the deep dive. Today, we're plunging into a topic that really underpins optimal infant health worldwide, the Baby Friendly Hospital Initiative, or BFHI. It's a pretty foundational framework for anyone involved in maternal and newborn care, and especially, I think, for those of you preparing for the IBCLC exam. Our mission for this deep dive is clear. We're going to unpack the 10 crucial steps of BFHI implementation. We'll delve into the various performance indicators, how success is measured. We want to illuminate all the important parts of training and counseling skills and clarify those quality indicators that are just essential to BFHI. And yeah, we'll even tackle some practical IBCLC exam style questions towards the end to help you really solidify your understanding. We've pulled insights from comprehensive WHO and UNICEF guidance, so you know this is the definitive information. Get ready for some hopefully surprising facts and maybe some aha moments that will make you feel truly well informed. Let's get started. Okay, let's unpack this then. The Baby Friendly Hospital Initiative. At its core, what is it trying to achieve? And why is it so incredibly vital in those first precious hours and days?
Well, it's fascinating just how critical those initial moments really are and how much difference a structured approach can actually make.
Yeah.
Since 1991, the BFHI has been this global motivator, right?
Mhm.
Aiming to prevent an estimated 823,000 deaths in young children every year simply by improving breastfeeding practices, which, when you think about it, raises a really important question.
Hmm.
How do we cut through all that noise? The confusing and often conflicting information families get from, well, everywhere, family belief, community practices, and maybe most insidiously, commercial advertising.
Yeah.
BSHI provides that clear, evidence-based roadmap.
That's a staggering number of lives impacted. So, within this BFHI framework, when we say optimal breastfeeding practices, what exactly are we talking about? How does BFHI define that?
That's a really critical distinction because optimal isn't just about like how long you breastfeed. It means exclusive breastfeeding for the first 6 months, definitely. And then continued breastfeeding for up to 2 years and beyond with, appropriate complementary foods added in. But it goes deeper than that. The framework emphasizes immediate and uninterrupted skin-to-skin contact, exclusive feeding, responsive feeding, which I know we'll dive into later, and crucially, counseling on the risks. The risks of supplementary feeding, bottles, teats, or pacifiers, which, let's face it, often challenge that optimal state.
So it's not just about the breast milk itself, but the method of delivery and the whole the relationship around feeding. What are the tangible benefits BFHI aims to protect for both the baby and the mother by promoting these practices?
Exactly. For the baby, human milk gives them complete nutrients, it's easily digested, and it offers this really robust protection against a whole range of infections, diarrheal, respiratory, ear infections, even meningitis, UTIs. Plus, there's long-term protection against chronic diseases later in life, like obesity, hypertension, diabetes.
Wow.
And for the mother, well, it costs less, obviously. It strengthens that incredible bond. It helps the uterus return to its pre-pregnancy size, helps prevent anemia, and significantly reduces her risk of ovarian and breast cancer. It's really a win-win on so many levels.
But there's also a flip side, isn't there? What are the risks when breastfeeding isn't established or supported and artificial feeding kind of becomes the default?
Yeah, the risks are pretty substantial. When breastfeeding isn't established, it often means more effort is needed for that mother-baby bonding. The baby faces increased risks of illness, especially diarrhea and respiratory infections, often because of contaminated feeds if formula isn't prepared safely. There's also a higher likelihood of malnutrition, vitamin A deficiency, allergic conditions like eczema and asthma, maybe animal milk intolerance, and long-term, these babies face that increased risk of chronic diseases, diabetes, obesity.
And for the mother.
For the mother, risks include getting pregnant again sooner, anemia, and higher chances of developing ovarian or breast cancer down the line. It's really about these cumulative health impacts. And if we connect this to the bigger picture, it's not just about healthy full-term infants. The BFHI principles are also explicitly designed for the small, sick, and preterm newborns.
Mm.
For these vulnerable infants, human milk is basically considered a medicine.
A medicine.
Yes. It's empirically supported, safe, effective, available, cost-effective. And it significantly decreases really serious complications like necrotizing enterocolitis, that's a devastating gut disease in preemies. Also late-onset sepsis, serious blood infections, and retinopathy of prematurity, which can cause blindness. So human milk isn't just nutrition here. It's a really profound protective agent.
That's such a powerful way to put it. Human milk as medicine. And for those vulnerable infants, we have to acknowledge the challenges in neonatal wards, right? They can be noisy, bright, intimidating, often leading to separation. So if a mother's own milk isn't immediately available, how does BFHI address that gap?
Right. In those critical situations, donor human milk plays a really crucial role. It acts as a bridge when the mother's own milk isn't available yet, or not in sufficient quantity. It provides many of those same protective benefits. The focus absolutely remains on human milk as the primary nutrient and protective agent.
Okay, now that we understand the profound why behind BFHI, let's roll up our sleeves and look at the practical blueprint. It all starts not just at the bedside, but with these foundational management procedures, the policies, the ethical guardrails that kind of create the whole environment for success. What's really interesting and maybe surprising to some is that the very first step, step 1A, isn't clinical care. It's about compliance with the International Code of Marketing of Breast Milk Substitutes. Why is this aspect so foundational to a hospital initiative?
That's such a crucial starting point because it protects the integrity of healthcare. You know, what's critical here isn't just like the obvious billboards. It's the more insidious velvet glove approach. Manufacturers use all sorts of methods. Internet ads, free samples, gifts, branded pens or calendars given right to healthcare facilities and staff.
Right.
These aren't just harmless gifts. They subtly normalize formula use. They often erode the confidence in breastfeeding, first among healthcare providers, and then, of course, among the families they care for. So, health workers and facilities must refuse these gifts, sponsorships, promotional materials. This whole concept of spillover, how even indirect promotion risks undermining a mother's confidence and encouraging artificial feeding. That's why this step is so vital.
So what should facilities do?
Well, specific actions include things like storing feeding supplies out of sight, and if formula is medically needed, transferring it to generic, unbranded containers. It's really about removing that commercial influence from a medical decision.
That makes perfect sense. Okay, so beyond those external influences, facilities also need a strong internal structure. Step 1B talks about facility policies. Why is having a written infant feeding policy so crucial? How does it ensure consistent care?
Well, policy really does drive practice. It's the vehicle, if you like, for making sure patients get consistent, evidence-based care. And it's an essential tool for staff accountability. A good policy has to encompass all 10 steps, detail how the code is implemented, and outline how staff competency is assessed regularly. And importantly, the policy must explicitly state support for all mothers, whatever their feeding choice is. It has to ensure a non-judgmental environment. It's really the foundational document setting the standard.
And how do facilities actually track their progress, make sure these policies are working? What kind of data are they looking at for Step 1C, the monitoring and data management systems? How do they know they're truly baby-friendly?
Think of these as the critical health metrics for the facility's BFHI compliance and, quality improvement. They're tracking the journey of human milk initial use, exclusive human milk use, mother's own milk, or MOM use, and donor human milk use. But it goes deeper, especially for those vulnerable babies in neonatal wards. They track things related to parenteral nutrition, that's IV feeding,
Okay.
like when it starts, protein, calorie, lipid intake, how long it lasts. And critically, they track central line days. Fewer central line days usually means a quicker, safer transition to oral human milk feeds.
Ah, so it shows they're really using human milk as medicine.
Exactly. It's also vital to track the average age babies achieve full volume feeds, the age of first non-nutritive or nutritive breastfeeding attempts. Reads related clinical diagnoses like NEC or spontaneous intestinal perforation, and documenting maternal milestones too, like breastfeeding education, time to first milk expression, keeping milk supply logs. This data gets looked at regularly, unit-wide, to help facilities see where they can improve.
Right, but none of these policies or data points matter without skilled people actually doing the work. Step 2 is staff competency. What does it mean to ensure staff are truly competent, beyond just, knowing the theory?
It means comprehensive training, both pre-service and in-service, for all clinical staff. And the key is a balance. Online education is great for basic knowledge, but it absolutely has to be coupled with in-person interactive components. For skill demonstration, for practice, staff need to practice what they learn.
Makes sense.
And the education should be multidisciplinary to foster teamwork across different roles, nurses, doctors, midwives, everyone. While all staff need basic support skills, having individuals with advanced training like lactation consultants is invaluable. And importantly, mother-to-mother support groups, especially if they're supervised by trained staff, are recognized as highly effective for education and ongoing relatable support. It's about building a competent team.
Okay, so with the essential policies and trained staff in place, the real magic of BFHI happens at the individual level, doesn't it? Let's shift from the institutional framework to the direct, hands-on clinical practices that shape a mother and baby's daily experience, starting even before birth. Step 3 is antenatal information. What critical information should health workers be discussing with pregnant women and their families, and what are some common worries that need addressing?
Yeah, this is about providing evidence-informed breastfeeding counseling, but tailored to individual needs, especially for high-risk women, maybe those at risk of preterm delivery. Discussions should cover the importance and benefits of breastfeeding, including colostrum, that vital first milk, the global recommendations exclusive for 6 months, continued for 2 years or more, skin-to-skin contact, responsive feeding. We also need to proactively address common worries like breast size or nipple shape, reassure mothers about milk production, dispel myths. Crucially, while we need to talk about the risks of formula, group education on how to prepare formula should generally be avoided antenatally. It can inadvertently promote its use and undermine breastfeeding confidence.
Right. Undermine the main message.
Exactly. The goal is empowerment through accurate information focused on breastfeeding success.
Then comes the golden hour, or even minutes, right after birth. Step 4 is immediate postnatal care. What's the protocol for immediate skin-to-skin, and what are the incredible benefits right at that moment?
This step requires immediate and uninterrupted skin-to-skin contact for all stable mothers and their infants, ideally within 5 minutes of birth, and for at least 60 minutes. Mothers should be supported to initiate breastfeeding as soon as possible, usually within that first hour. The practice is just profoundly beneficial. It helps keep the baby warm, stabilizes breathing, heart rate, promotes bonding, helps breastfeeding get started by activating those natural reflexes.
Even after a C-section?
Yes, even in cases like C-sections, or if the baby is sleepy from medication, it's prioritized as long as both mother and baby are stable. And if the mother is unavailable or unable for some reason, a partner or another family member should be encouraged to provide skin-to-skin. You still get many of the benefits.
Okay, so once that crucial skin-to-skin contact is established, what's the next layer of direct hands-on support? Because for many new moms, the how of breastfeeding positioning latch can feel really daunting. Step 5 is support with breastfeeding.
You've hit on a critical point there. It's about translating that knowledge into actual practice. The expectation is that a skilled health worker, someone trained in breastfeeding counseling, should assess each mother and baby during an early breastfeeding session, ideally within 6 hours of delivery. They should provide direct, hands-on assistance with positioning and attachment.
What does that look like specifically?
Well, it includes explaining and demonstrating the 4 key points of positioning. That's baby's head and body in line, held close to mom's body, whole body supported, and baby approaches the breast nose to nipple. And the 4 key points of attachment: more areola seen above the baby's top lip, mouth wide open, lower lip turned outwards, and chin touching the breast. Another crucial skill we teach to all mothers, not just those having difficulties, is hand expression.
All mothers.
Yes, it's essential for establishing and maintaining milk supply, especially if the baby is sick or separated. And we stress that expressing should not hurt.
Okay, step 6, supplementation. This can be a tricky area, often misunderstood. Beyond the strict medical indications, what are some common misconceptions or maybe cultural pressures that lead to unnecessary supplementation? And how does BFHI counteract those?
That's a really vital question. One huge misconception is the idea that just a little bit won't hurt, or the societal pressure for the baby to sleep through the night immediately, leading people to reach for formula too quickly. BFHI's strict guidelines really emphasize that supplementation is only medically indicated for specific conditions.
Like what, specifically?
Okay, so low birth weight infants, particularly those under 1,500 grams or 32 weeks gestation, or preterm infants under 37 weeks. Also, documented hypoglycemia, severe dehydration with signs like high serum sodium or lethargy, or poor intake, indicated by significant weight loss, like over 8–10% by day 5, or if the baby still has meconium stools on day 5, or persistent jaundice due to lack of intake. Other indications include certain metabolic disorders, severe maternal illnesses like sepsis, intolerable maternal pain that isn't relieved by other interventions, or specific medications that are truly contraindicated for breastfeeding.
So the list is quite specific.
Very specific. And the main goals, even with supplementation, are always twofold. Feed the infant adequately and establish or sustain the mother's milk supply. So we prioritize the mother's own expressed milk first, then donor human milk if available. And only then commercially prepared infant formula designed for the infant's needs, never glucose water or anything like that.
And safety is key if formula is used.
Absolutely. Safe preparation and storage are vital. Using boiled water that's still above 70 degrees Celsius, getting the proportions exactly right, especially given the risks of bacterial contamination in powdered formula.
Got it. Step 7 is rooming in, enabling mothers and infants to stay together 247. What are the profound advantages here, even in special care settings? How do facilities make this possible?
Rooming in is just fundamental. It allows mothers to recognize those subtle feeding cues much earlier, it promotes stronger bonding and attachment, and it really helps establish breastfeeding by ensuring frequent, unrestricted feeding whenever the baby shows interest. We find babies cry less, they get colonized by the mother's safe bacteria, which is protective, and breastfeeding duration tends to continue longer even after discharge.
And for sicker babies.
Well, that raises the important question. How do facilities adapt? It might mean things like single-family rooms in neonatal units or ensuring there's dedicated space for mothers to sleep near their infant's care area. Unrestricted parental access is key, plus designated comfortable breastfeeding rooms. The core principle is always keeping mother and baby together as much as is safely possible.
Learning your baby's language, recognizing their feeding cues. Step 8 is responsive feeding. What should parents be looking for? And why is responding to these cues so important, both for the baby's feeding and the mother's milk supply?
Responsive feeding basically means feeding the baby whenever they seem to want it, and for as long as they want, based on their cues. Early feeding cues are crucial to recognize. Opening the mouth, rooting or searching for the nipple, being wakeful and restless, making little noises, bringing hands to the mouth, sucking fingers. Crying is actually a late cue. By then, the baby is often too distressed to feed effectively. Emphasizing response to those early cues reduces stress for both mother and baby, makes the whole process smoother, and it directly helps maintain the mother's milk supply by ensuring frequent breast stimulation.
Makes sense. Now, the use of artificial feeding tools often sparks debate. Step 9, feeding bottles, teats, and pacifiers. What are the documented risks, and what are the preferred alternatives when direct breastfeeding isn't possible?
Yeah, the BFHI guidelines are very clear on this because of the documented risks. These tools can lead to increased ear infections, dental problems down the road. They can interfere with a preterm baby's ability to learn to breastfeed effectively, sometimes causing what's called nipple confusion, where the baby struggles to switch between the artificial nipple and the breast. They can also stop the mother from recognizing her baby's feeding cues, potentially decrease milk production if they replace time suckling at the breast, and they can carry infection if not cleaned meticulously.
So what are the alternatives?
When direct feeding at the breast isn't feasible, alternative methods are preferred. Things like tube feeding for babies who can't yet coordinate suckling and swallowing. Using a syringe or dropper to place small amounts into the baby's cheek carefully, avoiding aspiration. Spoon feeding. And cup feeding. Cup feeding is actually highlighted as preferable to bottles for preterm infants. It involves holding the baby securely upright, letting them sip from the cup. It still engages their oral motor skills in a way that protects the breastfeeding relationship.
Interesting. Okay, finally, the breastfeeding journey continues long after leaving the hospital. Step 10, care at discharge. What essential support and coordination are needed for a seamless transition home? How do we ensure families don't feel abandoned?
It's all about ensuring timely access to ongoing support and care. Before discharge, a trained health worker should ideally observe a breastfeeding session, just to boost confidence and address any immediate concerns. Mothers need to know how to recognize signs that a newborn might not be getting enough milk. And, critically, they need to know exactly where to find ongoing support.
Like where?
From primary health care centers, community health workers, peer counselors, mother-to-mother support groups, whatever is available in their community. Follow-up care is especially important in those first few days and weeks after discharge, because that's often when challenges pop up. If we connect this to the bigger picture again, it's about creating a really robust continuum of care that extends well beyond the hospital walls, linking families into their community support network.
Okay, we've built a really strong foundation with the 10 steps, but for our listeners preparing for the IBCLC exam, applying this knowledge is key. Before we dive into some practice questions, can you quickly recap how those essential counseling skills we've touched on, like active listening, empathy, you mentioned them in step 3, how do they play a direct role in navigating these real-world scenarios?
Absolutely. It's crucial to remember that what of BFHI is only as effective as the how, and that's exactly where counseling skills come in. Instead of just delivering information, we use active listening to truly understand a mother's concerns, her experiences. Empathy allows us to validate her feelings, which builds trust. And using open-ended questions empowers her to share more, helping us tailor solutions effectively. These skills are really fundamental to every single step of BFHI, turning those guidelines into genuinely supportive interactions.
Fantastic point. So let's put some of this knowledge into practice then, IBCLC exam style. We've got some practical questions here, designed to be similar to what you might encounter on the actual test. Let's think about the why behind each correct answer, linking it back to the BFHI framework we've just unpacked.
Right. The key now is to connect these scenarios directly back to the BFHI principles we've discussed today. Let's walk through some examples and see how these concepts really apply in practice. Okay, here's our first scenario. After a skilled assessment and proper management of breastfeeding, which of the following conditions is actually a medical reason for supplementation for a healthy term newborn? Is it A, baby may need supplementation until breastfeeding is assessed and corrected? B, baby should be bottle fed immediately to make sure of intake? C, infant should be exclusively formula fed because mother's milk is inadequate? Or D, significant dehydration?
Based on step 6.
Exactly. The correct answer here is D, significant dehydration. This lines up directly with our discussion in step 6 about medical indications for supplementation. While the other options suggest actions or assumptions, severe dehydration is one of those few explicit medical indications for supplementation in an otherwise healthy term infant requiring immediate action. BFHI always prioritizes human milk first, right? So exclusive formula feeding would only be considered in extremely rare specific circumstances, and just jumping to a bottle without assessment isn't the BFHI approach at all.
Okay, got it. Next question. What is the most likely reason why a baby is not getting enough milk? Is it A, baby hasn't had enough sleep and is tired? B, baby's feeds are limited in length and or frequency? C, mother is depressed? Or D, her milk composition is too low in calories and fat?
The answer here is B. Babies' feeds are limited in length and or frequency. As we learned when we talked about responsive feeding and milk supply, milk production is basically supply and demand. If a baby suckles less at the breast, maybe because feeds are too infrequent, or maybe no night feeding, the mother's milk supply will decrease. This directly impacts how much milk the baby actually gets.
Right.
While things like a tired baby or maternal depression can indirectly affect feeding, and true milk composition issues are pretty rare, insufficient frequency or duration of feeding is the most direct and common reason for insufficient milk production or transfer. It contradicts that responsive feeding principle in step 8.
Okay, next up. What should you suggest to new parents for calming their infant who continues crying even after an effective feed? Your options are A, wait until the baby cries before feeding it. B, let the baby cry it out, don't let them manipulate you. C, mother or partner can hold the baby in skin-to-skin contact. Or D, crying is a good exercise for the baby, don't worry.
The correct answer is C. Mother or partner can hold the baby in skin-to-skin contact. This ties right back to step 4 on immediate postnatal care and also step 7 on rooming in. We emphasize how skin-to-skin helps keep the baby calm, promotes bonding, can reduce crying. Remember, crying is a late feeding cue. And responsive feeding, responsive care really, means addressing the baby's needs, which definitely includes comfort and closeness, not just hunger. The other options just contradict principles of responsive care and bonding.
Right. Okay, here's one about antenatal counseling, relating back to step 3. A first-time pregnant woman asks, I'm afraid I might not have enough milk for my baby, like my sister didn't. I want to make sure I know about bottle feeding too. How often should I formula feed while I'm still breastfeeding? Which response is most appropriate? A, early skin-to-skin and frequent breastfeeding will make enough milk. B, the answer depends on whether you get help from different providers. C, it seems you're worried about not being able to exclusively breastfeed. Could you tell me more about that? Or D, you'll have enough milk, don't worry, breastfeeding is natural.
The most appropriate response is C. It seems that you are worried about not being able to exclusively breastfeed your baby. Could you tell me more about that? This response really demonstrates those key counseling skills, active listening, empathy that we highlighted as vital in the BFHI framework. It allows the health worker to understand the mother's underlying concerns from her perspective, and it builds trust. That's essential before you start giving information or reassurance.
Yeah, just jumping to reassurance might not actually help.
Exactly. Dismissing her worries or giving generic advice wouldn't effectively build her confidence or address her specific fears.
Okay, let's talk formula preparation, crucial safety aspect from step 6. Which step about safe preparation of formula is correct? A, feed the baby immediately after mixing powder with boiled water. B, use boiled water and add formula while water is above 70 degrees C. Use reconstituted formula within 4 hours. Or D, routinely add 1 scoop of formula to 30 cc boiled water.
The correct step here is B. Use boiled water and add formula while the water is still above 70 degrees Celsius. As we detailed, powdered infant formula isn't sterile. It has to be mixed with hot water, specifically above 70 degrees C, to kill potentially harmful bacteria like Chronobacter. So you boil the water, then let it cool for no more than 30 minutes to reach that temperature before mixing.
And the proportions.
Oh, absolutely critical. Proper proportions are vital for the baby's health, and you should always follow the manufacturer's instructions precisely. Never just guess or use standard scoops to standard water amounts without checking.
Right. Okay, next, regarding alternative feeding methods from step 9. What is an important element of safe cup feeding? A, cup is rocked quickly back and forth to maximize intake. B, baby is asleep. C, baby should be held securely upright. Or D, baby is lying supine on a flat surface.
The correct answer is C. Baby should be held securely upright. As we discussed, when cup feeding, the baby needs to be held securely upright. This allows them to sip the milk and control the intake themselves. This position significantly reduces the risk of aspiration. Rocking the cup, feeding a sleeping baby, or feeding a baby lying flat would be unsafe and could easily lead to aspiration or other complications. Directly contradicts the safe practices in BFHI.
Okay, and one more on cup feeding. Which of the following is an unsafe action during cup feeding? A, allowing the baby to sip from the cup. B, holding the baby securely upright. C, pouring milk directly into the baby's mouth. Or D, placing a cloth under the baby's chin.
The unsafe action is C, pouring milk directly into the baby's mouth. As we just touched on, there's a significant risk of aspiration if you pour milk quickly into the baby's mouth during cup feeding. The baby can't control the flow, and that could lead to choking or aspirating milk into the lungs. The other options, letting the baby sip, holding them upright using a bib or a cloth, those are all parts of safe, recommended cup feeding techniques that respect the baby's ability to feed themselves.
Wow, okay. We've really covered a tremendous amount in this deep dive into the baby-friendly hospital initiative. From those rigorous 10 steps covering everything from, marketing ethics and management procedures right through to responsive feeding and discharge planning to the nuanced counseling skills and those vital quality indicators. It's clear BFHI is far more than just a label on a hospital door, isn't it? It's a really comprehensive approach to infant care.
It really is. And, knowledge is most valuable when it's understood and applied. This deep dive into BFHI isn't just about ticking boxes for an exam. It's about truly empowering health workers, and by extension, ensuring optimal starts for some of our most vulnerable populations. There's always more to learn, of course, and multiple perspectives truly enrich our understanding in this critical field. It helps us connect the what to the why and the how.
So, what does this all mean for you, our listener? We've explored how this global initiative translates into concrete actions, actions that support breastfeeding and optimal infant feeding. Think about how these principles can impact every new family's journey, making a tangible difference right from the moment of birth through their transition home. What stands out to you from today's discussion? And here's a final thought to mull over. Consider how these foundational BFHI principles, with their emphasis on support, informed choice, evidence-based care, how could they extend beyond the maternity wards? Could they shape broader community health initiatives, transforming support for families at every single stage of their infant feeding journey?